It is 4:30 p.m. and I'm calling the August 20th, 2026 Board of Health meeting to order. If there is no objection from the board, I would like to amend today's agenda to include an ARPA septic update from Mike Kuzemka to the department updates section before Lori's administration updates. Are there any objections? Okay. Seeing none, we'll have that. Are there any other amendments that the board would like to put forward at this time to the agenda? Okay. The next item is approval of the previous meeting minutes. The minutes from the meeting on one moment. Let's see, that is from July 2026 that you have in your packet have been distributed. Are there any corrections or additions? Or is there a motion to approve the minutes as distributed?
I'll make a motion to approve.
Second.
All in favor?
Aye.
Aye. Meetings approved, minutes approved. Next, we have general public comments, and I will read. The Monroe County Board of Health encourages and welcomes public input. Written comments may be submitted at any time via email at boardofhealth@co.monroe.in.us. During meetings, comments related to specific agenda items will be heard after the board's discussion of that item and prior to taking a vote. At this time, we would like to invite those who would like to comment on any non-agenda items to speak. For those attending in person, please sign in at the front of the room, and those joining us online, please use the raised hand feature to indicate you would like to provide comment. Each speaker will have 3 minutes, and we ask that you please begin by stating your name for the record. I do think we have, do we have one person signed in or two? I'm sorry, yes, two. Okay, so we have 2 people signed in, and do we have anyone online so that I can go back and forth? Is there anyone with their hand up? Okay, so who do we have first on the sign-in sheet? Yes, yes.
Do I stay here or do you want me somewhere different? This way?
If you want to just stand.
Whatever's easier for you, makes no difference. I'm gonna be very quick. Where should I go?
Yeah, right. Yes.
This, okay.
Sorry.
Well, very briefly, hello, everybody, and thank you for your service on the board. It's a crazy time in the verse, and it's important work to do. My name's Terry Amsworth. My wife and I live in Bloomington. I teach part-time at IU with an adjunct. And I'm here, though, to say a brief word about the Monroe County Health Equity Council. Brief because I have 2 minutes left. The CAC purpose, it's sort of a cross-sector organization looking to help provide voice to those who may not always be heard fully in health decisions and services in Monroe County and environments. And we grew out of the Robert Wood Johnson funded Community Voices for Health Monroe County grant back 2020, 2023 era. And we're now moving forward from there. There's a leadership team we're doing in the midst of fundraising and a bit involved in planning processes, including for the county Department of Health for health planning related, and hope to do more of that. I'm here today mainly, though, to get to the main point. We held at the end of last year, November 1st, what we called our first porch party. And the porch party is a way to help bring together people to identify their health related. We see health somewhat broadly, including social determinants of health and such, to talk about their needs and interests. And it was done with the great support of United Way. And by the way, Randy Rogers, who's on the leadership team of MCAC, hoped to be here today, but his schedule didn't allow. He'd probably be talking rather than me. But this I wanted to give, and I think there are 5 members. Is that correct? I thought I had 5 copies, but maybe I only have 4. No, there's 5. So if there's 5 members, there's one. I know paper's bad, but nonetheless, what this is is a report of a write-up with some details of this porch party. It was done in conjunction with Habitat. It was held at RCA Park. It was done with support for children and youth to be present and participate. It was done with Spanish translations as well as needed. And it had about, if I recall, 60, 70 people there. Not a bad thing. Public engagement is hard. Public engagement about health can be hard. This brought a bunch of people out to talk about their needs, and this report documents that in some way. You have to kind of read to get to it a little bit, a lot of, here's what we are, here's what we, blah, 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 it's done. But I give you that, not because I'm going to talk about it a lot, you can read it hopefully if you read pleasure. But the CAC can be an ally to help engage voices in those arenas where you're looking for voices to be engaged. I encourage you to look at it and think about how it can be helpful. There are health-related planning processes from different sectors and sources about to begin or thinking about or deciding if they will in the strange world we live in. And we're happy to be supportive. I will say and wrap up that one of the things we're doing, we're updating one of these
Sir,
publications.
your time is up.
No, it's the way it goes.
Thank you for going.
He was wrapping up.
Yeah.
Thank you.
And thank you for bringing the report.
Thank you.
Okay, and we have another person for public comment. One moment, there's no one online, is that correct? Okay, please, will you introduce yourself?
Because I regret having to come to spend your time and my time to speak about this. My name is Christina Kemp. I'm a former employee who resigned from my position as public health nurse last month due to working conditions and the treatment I was receiving from the administrator and the health officer. I worked in public health for close to 20 years. The last 10 here in the health department as preparedness coordinator, health educator, and for the last 5 months as public health nurse. In 2022, I was awarded Public Health Hero from the Indiana Public Health Association after being nominated by our previous administrator. I share this to provide context to my background, experience, and dedication in contrast to the concern I will share. I've never been subjected to such a dismissive, unsupportive, and at times unprofessional atmosphere as my most recent time here. This is no reflection to staff. I offer this information not merely as another disgruntled former employee, but to provide insight into possible reasons for high turnover that have plagued this department for the past few years. From February until my time of departure, I was the only public health nurse on staff, briefly, except for briefly another nurse who was in training that resigned, and for Kathy Hewitt, who thankfully took on TV during a good portion of my time, in addition to her role downstairs. While I was performing my duties and managing multiple aspects of other nurse positions, I could not understand why I was being treated so poorly. I was denied training opportunities critical to the safety of my functions as a registered nurse, and I was denied time off requests that culminated in threats of termination. I felt the need to involve HR in order to obtain approval of FMLA time to take care of my mother, whose health declined and passed away during this time. The health officer, who months ago after meeting with HR, was barred from coming to my office or speaking to me alone, simply continued the same behaviors in Lori's presence, who had no objections. It seemed counterproductive to me to treat a dedicated employee with considerable experience, institutional knowledge, lifelong interest in public health, and a desire to continue to learn new skills in a way that I could conclude that it was only intended to encourage me to resign, therefore leaving Monroe County with 0 public health nurses. I was not willing to continue to be taken advantage of simply because I was the only nurse willing to accept the impossible task of covering the duties of 3 positions in a clinic with no adjustment in the expectation that what was involved that would be possible. Nor was I willing to risk my license through potential needless vaccination errors that could occur without proper training. And I was not willing to continue to be subjected to the type of treatment neither I nor any employee who previously left Monroe County Health Department voluntarily or involuntarily deserved. At some point, one has to begin to consider where the actual problem lies. I truly hope I truly do hope the best for this department and success for the clinic, for the sake of our residents, that future nurses that are brought in can receive appropriate training to be competent in their assigned duties, and that they and all employees can be treated with basic respect. A packet of important information will be shared. I'll give that to you, Dr. Robinson. And I encourage all board members to at least review the cover letter, which kind of details a lot more specifics and some of those things that I'm sharing here, along with emails that kind of support my position. I do thank you all for what you offer to Monroe County and serving here on the boards. Thank you for your time and consideration.
Thank you, Christine.
Thank you.
The next item on our agenda is department updates, and we'll start with the ARPA septic update with Mike.
For the ARPA septic program, it ends and systems have to be installed and completely built by September 30th this year. We have 4 remaining systems in various stages that are in production or getting ready to begin production. So we're coming to the tail end of it. So on the water end and my end, we're just hoping for good weather right now so we can get those systems completed. I've already been in contact with the homeowners and installers that if you don't think you can meet that deadline, we need to terminate the contract and that money is going to be allocated somewhere else.
And could you speak just a little bit, because we have an item to, a memorandum to discuss
Okay.
later on about some of the challenges in getting those projects approved and all the working parts, and that may be, you know, Lori's role to tell us that. And so, because we have some funding that we had to return already to different departments, so we couldn't use all the funds.
Just for the ARPA program, at first it started with an application process and that began late 2024, like I'd say 3rd or 4th quarter. That's when we started getting the nuts and bolts of it together. And then some systems were, I think one system got put in place in the end of 2024 because of the weather. But in 2025, with weather conditions and whatnot, a lot of those projects got delayed until 2026 this year, but some did get installed. But now with weather constrictions, site restrictions,
Right.
communicating with the homeowners, contractors, the auditors, there's a lot of moving parts and pieces to it, and just getting to the end stage and getting a proper invoice and fulfilling the contract it's been a pretty rigorous process and a lot of communications. So,
Okay. Thank you so much.
You're welcome. So,
Does anyone have questions?
So has the project overrun the expected time due to weather considerations? And if so, how's the weather now compared to what was expected?
every season is different, but like the weather's not looking good right now. We've gotten rain all throughout this week. There's more rain coming this weekend. We just need then certain sites or they retain more water than other sites here in Monroe County, whether it's the highlands or the lowlands. So a lot of contractors believe they can get the systems in, but it's still, we need days of dry weather to get those systems in because they can't really begin the system installation without a soil test. So, yeah.
Thank you.
And the federal guidelines are pretty specific, so it has to be done by, there's a drop dead date, so to
Yeah.
speak, yeah.
Yeah, and that's the 9:30. So if they can't get it in or installed and built by 9:30, unfortunately, any work leading up to it, if you miss that deadline, there's no back pay. So yeah. Yeah, then also with the installers, a lot of the installers that they're beginning the work without like half payment in. So I mean, they are not getting paid until the very end. So I mean, they have limitations as well. So
Thank you so much.
you're welcome so much.
Yes,
So Mike, how many have been completely installed under the ARPA program?
Off the top of my head, I don't want to guess, but I can get you those numbers tomorrow. So yeah. I can email like Board of Health, or I can send to Lori and we can get them out. So
Okay, yeah, just so we have a sense of, you know, if there are these 4 remaining, but how many did we actually manage to do to improve the health and well-being of our county?
yeah, I can get you guys those numbers tomorrow. So.
Thanks.
This may be futile, probably is, but is there anything that we can do as a Board of Health?
We just need good weather right now. So as right now, we just need good weather. get those systems in. So, I mean, because September 30th is coming up, so yeah.
We
No
can take
more
it, we can take
rain
it both. by the
We
way.
could do a rain dance.
No more rain dances.
Lots of.
No, yeah, quit there. No more rain dancing.
Yeah.
Yeah, whatever we do, yeah.
I don't know if that takes a resolution by the board for no more rain dances or.
You're welcome.
Thanks.
Our next update is from Lori, administration, and we have.
Okay, just to start off with vital records, the Indiana Department of Health has completely stopped providing the burial transit permit forms that we used to get from the state. So vital records is essentially having to develop their own system for these forms, printing, distributing, and tracking these permits. The system that they have in place so far is going smoothly without any issues, but that's one change that they've been working on. The director and assistant director will be attending the Indiana Vital Records Association Fall Conference that's going to be held in French Lick in October of this year. Year to date, as of August 18th, Vital Records has had 81% of their customers who have been able to meet the Health First Indiana residency restrictions. And the remaining 19% still has to be served by that non-HFI funded employee that they have. We have recently interviewed 2 candidates for nursing positions. Neither candidate has moved forward in the recruitment process at this time. One is just recently finished school and has not taken the exam for licensure yet. And the other has concerns about a lack of a manager coming into the department. We currently have 60 open case investigations that need to be started. There's a total of 108 investigations in the work list and the queue. So we have Kathy Hewitt is still continuing to cover TB and the LTBI patients, assisting with our cyclospora cases, assisting with additional cases when time permits. Linnea is helping with our lead case management. Mike is doing a great job with the animal bites and the tick-borne illnesses, so helping to relieve some of that from the work list.
And the cases that we have currently, the new 108, what you're describing is included in that? Or,
Yes. Mhm.
okay,
So the 108, so there's 60 that have not been started as of today. There's of that 108 that the rest remaining are being worked on. So some of those you just work on continually over time. Maybe you have to try to reach back out to a patient because you couldn't connect with them the first time. If there's someone who on medication, so those would just stay kind of active until they can be closed out. The Indiana Department of Health is actually the one that then will review a lot of those cases and then close them out. So there are ones that stay open because there's periodic check-ins or it's being waited on for the state to review. Does that help?
do we have these staff members who are able to start working on the 60 cases?
We really don't have the capacity. They're trying to little by little work on those high priorities. So the high priority cases, we get notification to begin working on those. Some of the lower level cases are just sitting there until we're able to get capacity and to start working on those. Monroe County has had a total of 8 cyclospora cases since May 1st of this year. Statewide, there have been over 2,000 cases. Moving into the maternal child health, our coordinator currently has 8 active participants in the Quit for 2 smoking cessation program. 6 of those are prenatal and 2 are postpartum. She's distributed 154 bottles of the donor breast milk since April. So that program with the milk bank is continuing to be successful and busy. She's going to be partnering with the Bloomington Mobile Integrated Health on September 25th. They're going to be hosting a car seat safety inspection clinic. This will be held from 3 to 6 p.m. And in addition to the safety checks, they will have car seats available. If they have a family that arrives and it's damaged, expired, the child has outgrown that height or weight. And these car seats will be coming from the state's automotive safety program. Here in the health department, we have seen an increase in referrals from the Hannah Center and Tandem just due to supply. So we're able to provide those families in need with car seats, and so they still have access to those resources. So we've seen an increase in the ones that we are distributing. She's gonna be starting the GOAL program, so that's the Get On Board Active Living program. This is in collaboration with Indiana University. This goes from September 15th to November 10th, from 6 to 7:30 p.m. at the Banneker Community Center. This is a free program. It's families, children age 7 to 17. And if families have children that are younger to 7, childcare is available at the center on site while the program sessions occur. Essentially, during the 9 weeks, families participate in interactive games, hands-on cooking demonstrations, taste tests, and then they're able to learn about food, physical activities, sleep, and building a positive self-image. Our disease intervention and harm reduction team are still doing drop-in testing on Thursdays from 3 to 6 p.m. They're seeing at least 4 different people at each session. So continuing to go well. They're also able to bring in patients who might not be able to connect with otherwise during these drop-in times, which is helping with their workload. They're going to be attending Pride Fest on August 22nd and 2 different IU Welcome Week events, providing educational materials, supplies, and promoting free services. On September 26th, they'll be offering testing at the Brown County Pride and offering pre-testing October 3rd at the Spencer Pride. Specifically with harm reduction, they have had 34 participants for the HIV and HCV wrapping testing services in 1 month. This is the highest amount of people who have been tested in a single month for the entire duration of the harm reduction program. So far this year, 9 new hepatitis C cases have been identified through these free testing services. They're continuing to work on the Narcan Behind Every Bar program with the city of Bloomington. So that's going well. They're now allowing local businesses to have individually scheduled trainings for naloxone for staff members. Nix is the next business scheduled for training in September, and the Bluebird is in the process of scheduling. Our preparedness director and coordinator are scheduling back to school vaccination events in collaboration with the Indiana Department of Health. These will be held at the libraries in mid-September and a drive-through event in late September. They have distributed public health emergency supplies to 76 individuals in August so far. This includes the 3-in-1 flu and COVID tests and summer safety kits that include a small sunscreen, cooling cloth, tick remover, and informational card, and other safety educational materials. And they are preparing for an upcoming local emergency planning committee, a functional exercise event that's going to be held in September. I do have a presentation that I want to go through next, if there aren't any questions about this information.
I do have a question about the burial, the very beginning.
Yes.
Is our form in coordination with our surrounding counties, since we often have cross-county burial issues?
That I do not know, so I was just trying to learn more about this today, and I haven't seen the form that the permit that they've actually developed and how that compares to other counties. But I'll certainly ask about that.
Would you, because
What's the consistency and
I know that we have grant bodies that come here or have to go to Green, and that our funeral directors
mm,
are going across county lines, and it just for a sense of ease
mhm.
and their understanding, it'd be great for it to be coordinated regionally,
Yeah.
or at least in our little tiny region.
Mhm.
Thanks.
Okay, any other questions? Do you have that? Do you have, okay, please. So I know there's a lot on the agenda. I'll try to be brief. Okay. So I just wanted to take some time to have a discussion about the nursing services. So in working on gathering information, I decided to first start with taking time to gather some employee feedback on the different divisions that we currently have in the department and how they are functioning. So this first question, what challenges would your division experience without a defined management structure or manager overseeing division operations? The feedback here to this question has identified a lack of structure, direction, and accountability as significant challenges without a defined management structure. Employees also express concern that without a manager with division-specific knowledge and authority, there are unclear expectations about roles and who to lean on for division-specific guidance. I won't read off each of the individual feedback. The next question, what are the benefits to having a division manager? The feedback to this question consistently identified a division manager as the important source of leadership, structure, accountability, and expertise. Employees expressed how a dedicated manager provides a clear point of contact when they have questions, when they need guidance, or for decision-making. How could public health and community safety be impacted without a division manager? These responses seem to highlight concerns that the absence of a division manager could directly affect the department's ability to respond effectively to public health needs. Employees emphasize the importance of having a qualified leader available to provide timely guidance, coordination, and support for decision-making. One experience back with COVID in a pod identified an example of how the absence of a designated leader creates confusion when unexpected situations arise. I want to lead this into what I am proposing for a case for sequenced hiring plan for the nursing services. I feel that the recommended hiring plan should include first starting with securing that health services director as the anchor of the manager of our health services. Then moving into the clinical assistant and public health nurses, and then moving into developing and requesting the creation of a nurse supervisor position. So what I'm proposing is phase one, hiring the health services director. So building clinical nursing services without an established manager creates a really significant gap between hiring nurses and a clinical assistant and having the infrastructure necessary to ensure that staff are prepared and competent to practice within the local health department's scope of services. The health services director really would be establishing the foundation. So continuing into phase one, some of those initial responsibility, of course, they would have to complete the required trainings through the Indiana Department of Health, develop what competency validation processes they're going to use to train, evaluate, do skills checkoffs with the nurses and the medical assistant, refine clinical documentation standards, lead recruitment and selection of nurses and a clinical assistant. I really feel here in the department, when we have managers of divisions and there's vacancies, that they are able to take ownership and review the candidates, perform those interviews, and select the individuals that they feel are best for their team. Starting with having a health services director, this person would then be able to lead the recruitment of the nurses and the clinical assistant to build that strong team unit. Phase 2, build the nursing services team. So the purpose of this hiring structure really is to establish safe, organized, and sustainable nursing services within the health department. So rather than simply filling positions, the health department can ensure that every nurse receives competency validation, clear escalation pathways for medical issues and concerns, ongoing clinical performance feedback, and access to appropriate clinical management. The public health nurse training period during weeks 1 through 3 is really focused on mandatory trainings. We've been using a 6 weeks training period that's primarily, it's really just been focused on online trainings. They have not had the hands-on training experience without a nurse supervisor or nurse director to do hands-on training. While this is going on, the health services director would still be actively engaged, support the nurses with that hands-on training, ensure trainings are being completed timely to meet target timelines, being able to use validation tools and skills assessment, and then leading and finalizing the hiring process to onboard a clinical assistant. So some examples for weeks 1 through 3 with the clinical assistant, reviewing with the health services director the workflow, learning and training on CHIRP, vaccine program management, all of our different systems, scheduling, clinical supply management, clinical activities within their scope, emergency procedures, and opening and closing procedures. So during this time, that also really allows for that one-on-one collaboration with the health services director and clinical assistant. So they can begin forming a strong team to test workflow options, to identify gaps and inefficiencies, be able to refine processes that are needed, and develop consistent support routines. Moving into the end of the week 3 into phase 4, be able to bring the nursing team together. So this really is just about now how can the team begin to continue their training, learning, and working with one another. They can begin applying skills as applicable to their scope as their training continues. They can participate in mock trainings in the clinical environment, begin doing some of the additional trainings that are needed to really get up to speed with skills and competencies. Oh, sorry. And once the nurses complete the mandatory trainings, the health services director can then begin to transition the team into the local health department, orientation and clinical implementation. So some of the ideas for specific tasks to begin those local health department specific orientations for patient care, review the nursing policies and procedures, workflows, more hands-on training, and establish individual clinic responsibilities within this team unit. Phase 5, transitioning into clinical operations. With orientation and competency completed, the department can then transition into more routine nursing operations. The health services director can move towards overseeing and strengthening the established system. Here's just a recommended staffing philosophy that really needs to start with building a strong managerial foundation with the health services director. then bringing on the nurses, the clinical assistant for training, building clinical support, building the team together, establishing competency and timeframes for launching services, sustainable supervision, and approval of a nurse supervisor position in the future, I think is also going to be key for just long-term success within this division. If we are able to gain approval of a nurse supervisor position, then a transition can occur between the health services director and that nurse supervisor. So here's just an image of that long-term staffing model, the health services director, some of it is on the board, the nurse supervisor, 3 public health nurses, and 1 clinical assistant. So this model places an RN supervisor, so there is someone overseeing those day-to-day clinical and operational duties, and can be a support system for the nursing team that's readily available and they're participating in the clinics. The long-term vision is a health services director and nurse supervisor staffing model that can oversee nursing services and really establish a sustainable division. This will allow the health services director to then function at their appropriate level of leadership, and the nurse supervisor can then become that link between the division leadership and then that frontline service delivery. The director can move into providing that broader direction, and the nurse supervisor can then translate that into daily operations. So why is an RN supervisor important? I believe one of the strongest reasons for the department to focus on developing this RN nurse supervisor is to ensure day-to-day clinical safety and compliance. An RN supervisor would provide daily supervision and support. We bring in LPNs and medical assistants. Those are the people handling immunizations, the communicable disease, health. This will, when a need arises, they'll essentially have someone there who can recognize and step in. So just try to provide some brief examples of how situation can escalate. So incorrect vaccine documentation. If you have a nurse, they administer a VFC vaccine, the vaccine information is entered incorrectly into the patient's record. Many things could occur. If you don't have someone who is directly overseeing these operations, like the nurse supervisor, then it could be a long time before it's recognized or realized and then able to be corrected in the system. Vaccine storage temperature excursion. So we have a maternal child health coordinator taking temperature logs, identifies that it's outside the appropriate range. There's a vacancy in the health services director. There's no nurse supervisor. Then who does that person go to? So just in this scenario, could be trying to go to me and I'm out of the office. The other point contact person is also out of the office, leading to a situation of who do we go to next, because that person does not have a manager or a supervisor to go to. A patient fainting, you could have 2 nurses, they've completed their online trainings. They don't have an RN supervisor. They didn't receive any hands-on training. They didn't have an official review by an RN supervisor. So say nurse C administers the vaccine, the patient falls out of the chair. They try to call out for help. The other nurse decided to take an early lunch. There's no one else in the clinic, and essentially without the supervisor, the nurses were left to try to rely on one another. A needle stick, or blood fluid exposure. This could be an example of the clinical assistant sustaining a needle stick injury, not sure about what to do. They don't have a supervisor immediately available to go to. Maybe they're uncertain. They don't know whether the incident is urgent or not. They don't maybe know without that supervisor there in the space with them, whether they should continue patient care or leave the patient to determine what they should do next for their injury. Managing multiple tasks and responsibilities. You have a clinical assistant who might be rooming patients, answering the phone, trying to cover walk-ins, cleaning rooms. They need to take a patient down the hall to vital records to pay. And the other nurses are busy doing other tasks. The clinical assistant's overwhelmed, not sure what to do. You have an RN supervisor there. They can step in and provide real-time assistance to then begin directing what to do next and help assist. You could have two nurses who know about work, but there's not anybody to coordinate it. So perhaps employees are aware there's multiple high priority tasks. Some tasks are missed. It's not because they don't care or they don't know. They don't have a designated supervisor who's coordinating clinical and operational priorities on a day-to-day basis. An RN supervisor can step in to identify, prioritize, assign, follow up, and verify. So bringing in long-term and RN supervisor would help cover clinical oversight and operational oversight. Without an RN supervisors, we know that responsibilities don't disappear. They're simply being distributed informally among employees who don't have the authority, training, or designated responsibility to necessarily perform them. An RN supervisor is an organizational safety net. Might not be highly visible if things are functioning well or appropriately, but it's certainly going to become apparent when something unexpected happens. It's not about whether nursing services can operate without an RN supervisor. The question really is, when something goes wrong, who's responsible for recognizing the problem, determining the response, directing staff, escalating the issue, and ensuring the matter is resolved. Currently, there is a gap, and that's one of the reasons why I think that it's really important to consider building in an RN supervisor to this health services division. Just to briefly kind of circle back around to why. So why were 3 different positions: the public health nurse, communicable disease, school liaison, and then just our general public health nurse created. So these are 3 slightly different positions. They have different titles, but this allowed the creation of primary, secondary, and backup duties to have more clearly defined roles and responsibilities. The case for clearly defined roles and responsibilities, this is really about accountability, having a predictable workflow, and a mechanism for resolving competing priorities. Can't really expect nurses who are expected to see what needs to be done and work out priorities among themselves. That can appear flexible and team-focused, collaborative, but it really creates an informal system where responsibility, authority, and accountability is unclear. Shared responsibility could lead to no responsibility. If all 3 nurses are responsible for everything, it creates issues with determining who is responsible for actually completing what task. You could have all 3 nurses who they may have aligned thoughts, or they might just be working on their own, and could just lead to an issue of lack of clarity. A staff should not have to negotiate priorities while also providing patient care. You have 3 nurses working on different priorities. You have an unscheduled patient walks in. Each nurse probably feels that their current task is important. However, without a supervisor, they now have to negotiate amongst themselves. Who's going to stop what they're doing? Whose task is more urgent? Who's going to finish the work that got interrupted? Who has the authority among them to make the decision? And what should be postponed? I'm expecting nurses to continually determine among themselves what is most important, places and additional management responsibility on clinical staff where a dedicated supervisor can be that independent decision maker who can say which nurse handles the patient and the remaining work, for example. That's management, and it's not something that should have to be routinely negotiated among peers. Mhm.
This, your presentation's good, but it sounds like you're trying to convince us. Are you practicing this for, for someone else?
Yeah, this needs presented really, I think, to the commissioners. We need to get on their schedule and just do a presentation and also for the council. I mean, so
I don't think there's anyone here that needs to be convinced that this isn't a good plan and that nurses play an important role. I mean, even nurse supervisor position, at least I see the logic in this. But I don't think we need to be convinced of this, but I think this should be done as a presentation to someone in authority. And the final question I have, how realistic is this that we can implement this in the current environment?
Mhm. That's why I really feel like without using the staffing agency to bring in that director first. So we have a staffing agency who's recruiting, they know people who are qualified, can come in, they have that background experience to be able to get that foundation settled, to then have that point person and that support to then bring in their team. And that's really a lot of the feedback that we've been getting from some of the applicants and some of the nurses. We don't have that person to go to, then that's really important, especially for that direct clinical work and for the hands-on. I'm almost done. I don't. But I think in part with this, I want to make sure that, are we aligned on a strategy, and for what we think should be the steps being taken, and the importance really of that public health nurse supervisor. If you look at our other divisions and they have that middle line, senior or assistant director, and that helps provide that extra layer of day-to-day support, backup coverage, and protection in my mind to the health department. Yes.
So that's a great presentation. Is this sort of some standardized presentation or something that you sort of developed de novo?
So I've been developing it, just kind of trying to piece together over time, like what are some of the different strategies? So if we've tried bringing in nurses without that support system, we know that that hasn't worked well. So what's the next phase that you can try to really be able to create a stronger foundation? And then that's what I think is just taken time to say, I don't really think this is gonna work until we get those levels of supervision in there.
So when looking at the board here,
Mhm.
I have trouble with recognizing what's written because I have color blindness. So
Oh, yes.
is that very top one, the HSD, that's what we're talking about, that's the position, right?
Yes, so that is our currently approved vacant
Okay,
health
okay.
services
I want to verify
director.
that. So we do have approval, but we don't have the candidates.
So we have candidates, we have interviewed candidates once they learn the scope. That changes, and we have candidates through a staffing agency, through the Emeritus, who could come into that role.
Hence the emeritus spiel in our. Okay.
Yeah,
So correct me if I'm wrong, though, what you've got written there, the difference is here in this proposal. We have the health services director with these three nurses directly reporting. The position she's talking about is in the middle, is what,
Public health
there's a
nurse
public
supervisor.
health nurse supervisor.
And a clinical assistant, which we don't have.
no, we do.
We do get this nurse assistant. We did get that one.
Yes, but we don't have anyone for the clinical assistant to be supervised under or by or trained or go to. And so for similar and also different reasons, the public health nurse focused on maternal child health. That's similar in that our maternal child health coordinator doesn't have a support person to go to. There's no backup capacity. So there are programs that at the beginning of Health First Indiana, she received training. We got the program materials. That was all part of the process of building the new position for Health First Indiana, but those haven't been able to be implemented because there's just not capacity.
I'm probably the only colorblind, red-green colorblind person in the room. If we could get that, if we could get like a bright blue and a yellow,
Okay.
because right now I see two colors. I see black and then I see some other, not black, but I can't tell the difference and it makes it difficult for me to understand that what's filled and what isn't.
Okay, so let's see. So,
Use the
we said
blue.
this is vacant,
Yeah, we
3
use the
nurse
blue, then-
positions are vacant,
Yeah.
clinical assistant. This is vacant, but we haven't included this in the grant. They just moved to the nursing, so we don't have grant, so we're not trying to actively fill that. We're also not actively trying to fill the senior community health specialist or the tobacco MRC. The tobacco MRC duties got moved into 2 separate positions. The tobacco was moved into the maternal child health coordinator. The MRC was moved into our director of public health preparedness. The senior community health specialist, those duties was helping a lot with the community health assessment, accreditation, and harm reduction. So we haven't been actively, we don't have approval to fill that. That work is being done by our population health and outreach.
But this is still the master plan. We hope to be able, if we are able to fulfill all the spots, then we have these positions.
This is what I envision.
Could we change one of those 2 colors to the blue instead of whatever it is?
Or could you simply circle the ones that have not been approved? That might help also.
That's great. Yeah, the blue there is really good. That I can see.
So let me ask the question, just so we're clear, I'm also in support of this, but the question that comes to my mind immediately is, as on this paper, the only issue I would have is explain to me why the health services director cannot do everything you just described as it is on this page with the 3 nurses. Because to me, I feel like that's one person, that person, I was checking, that's a nurse. Why can that person not be the backup, the trainer, the quarterback, all of those things that you're proposing the public health nurse do? Because I feel like that's the hurdle you're going to have to jump to convince
Yes.
that we need funding for this. Why does it have to be 2 separate positions?
So
Agree.
for a couple, so the health services director position was originally created when we were not doing the nursing services that we've absorbed from IU Health. So that position was already responsible for overseeing the other areas, the other programs. Once we knew that we were going to be taking on the IU Health services, those duties that were being covered by their RN supervisor, in essence, got lumped into, and our nurses got lumped into this director role.
So the old way would have been the health services director would be meeting with a nursing supervisor that IU Health was employing at Community Health, who then had these other pieces. So this is basically recreating that same structure that we tried to just lump into the health services director position.
Similar, somewhat. However, our nurses actually cover more duties than the IU Health nurses were because they're also covering all of the Health First Indiana for public health services. So for example, we used to have one full-time dedicated school health liaison. So that was regional, but we had one full-time dedicated school health liaison. That's now been added to one of the nurse on top of those nursing duties. Our programs, trauma and injury prevention, let's see, chronic disease. So some of the programs trying to be developed and worked on specifically for Health First Indiana have been lumped into the public health nurse position. So these are not simply covering the same duties, they're covering the same duties that were covered by IU Health in addition to Health First Indiana core services.
Okay. So my suggestion would be in your presentation, that particular piece needs to be very evident upfront. Because the whole time I was listening to, why can't this person be doing this job? Now that I understand, it makes complete sense to me.
I also think that practically, we've seen that the health services director could be out of the office. And then how do you balance that? Do you have to make sure the director's always here 8 to 4? Can they leave? Do they have to check and make sure? Because if they're covering for the maternal child health coordinator, that's how my schedule currently is. She has to tell me when she's gonna be out in the office and out of the office, because then I have to put it on my calendar to try to be backup for the people who are coming in for maternal child health services. It would be similar with the director having to coordinate that and with the nurses. So say you have the school health liaison nurse who's out in the community at the schools providing tobacco education. You have the public health nurse who's out in the community providing services for fall prevention. You have the communicable disease nurse, maybe they're on vacation, maybe they are here, but again, then you don't have anyone here. So again, it's falling on who are those backup layers that are picking up the day-to-day activities or the people walking in or the emergent situations that might be coming up. It's also hard to tell whether it could be done because we don't have anyone currently in the role. But we do get a lot of feedback that it's a lot of work lumped into one, and
If we had, sorry, more questions. I'm just trying to think, how are you gonna get questioned, right? If we had this public health nurse supervisor, do we still need a clinical assistant to the health services director?
well, I think that would depend on who's gonna be doing the billing, scheduling, answering the phone, cleaning and turning over the rooms, doing the inventory.
Okay, very good.
The same thing now. If we don't have a clinical assistant, say we get 2 nurses in, well, then who's dividing up? Who's gonna be answering the phone? Who's covering Joey when Joey walks in wanting a test?
So would that position then report instead of to the health services director to then the public health nurse supervisor as proposed?
I think so.
Okay.
Yes.
Yeah, to me, that's one of the most important positions. You
I
gotta
agree,
have
you gotta
somebody
have
to answer the phone and take the patients where they need to be taken. I mean,
This all makes good sense. I totally agree with, you've got to hire the director first, because that person got to set the vision. And then that person got to sell the vision to all the additional nurses that you're then gonna hire and create and organize the team. So I think that makes absolute good sense.
to me, I got bogged down sometimes in the responsibilities of the director versus the supervisor. You've got to make very clear what those different duties are in order for anybody, I think, to accept this plan.
Okay, so action
Excuse
plan,
me,
yes,
may I?
yes.
So I think that, there are 2 things I want to offer and suggest. One is while the board has approved Lori's going ahead to pursue contracting. The board has not actually approved the Emeritus contract
that's-
itself.
We're going to
And,
address that.
okay, so that seems really crucial. The other part is that I know that the question is going to be, you know, especially when you go to ask for a public health nurse supervisor, the question is going to be, why do you need a nurse supervisor when you don't have any nurses? There is no doubt in my mind that's going to be a major question, particularly from council, is, you know, why are you asking us for this thing when we don't have nurses? So, yes, I understand. And we tried to hire a director that was pretty much a failure. And clearly the second line is absolutely the nurses. And that services director being able to train and do that supervisor role. One of those nurses may rise, I would hope, like cream to the top as an evident person to move into that role. But I don't think that you are ever going to get council to approve a nurse supervisor before you have nurses, no matter how good the presentation is and how much sense it makes to the board. I think that you are going to bat your head against the wall. And that's just my impression of council and what the feedback.
So then what we're gonna continue to have is people like Christina who came to talk to us and say, well, I'm being asked to do all of these things because there's no one else. And so, I mean, there are a lot of moving pieces and parts. So I think we just need to decide on an action as a board. Do we continue? I think the decisions are, do we continue to try to ask cooperation with the commissioners, because that's gonna be an issue when we talk about the emeritus contract, and then also with council to try to create this so that we can be successful in keeping our funding essentially, so we can recruit people, have staff, keep our funding for Health First funds, because if we aren't able to provide these services, get people, then this part of what we do is going to go by the wayside. So we are at a juncture where we're gonna have to decide, are we going to give up on these services? And which I think would be insane. I mean, this is why we're here. And so we're trying to recreate what IU had provided for us. So do we keep hammering at that? Does the board want to do that? Or are we at a juncture where we say, hey, you know, this is super difficult. We can't provide what we need to provide. I don't want to be at this point, but I feel that's where we are.
Let me say something too. So in the presentation with the sequenced hiring plan, so that's why the long-term vision for the nurse supervisor was built in. That's later in the phase. So you have the director comes on board, recruits the staff that the director wants for their team, getting the nurses and the clinical assistant, and then you're moving on to, it's still going to be months and months and months to get through council to get approval and build the job description and budget to start for in 2027. So not now, but that's the long-term stability plan. And that wouldn't be now. We'd be focusing on who is our person we're going to get in here as that anchor for the director and let them bring in and build their team.
Okay, so do we need a motion on behalf of the board to give you the tools to do what you need, or do we?
I think I need clarification on what is the direction I can move in for that.
So
we
basically,
are
you want a yea or nay on this plan, right? On this, what you have outlined up here.
Yes, that's the plan that I see. And some of that happens immediately now. And the long-term vision is the public health nurse supervisor and the public health nurse maternal child health. Those will be coming into the full picture in 2027. I think those are critical positions that the health department needs for that long-term, strong unit.
But what you're proposing is this middle part of what we're looking at here. You would say, we're gonna
Yes.
post the health service director, fill that position. Once it's filled, then we fill the bottom
Then-
three,
Yes.
and then we're gonna come back and get the middle one that's in red.
Yes, health services director, nurses, clinical assistant, director can bring all the clinical team in. And then in that process, we be working on then moving to build the supervisor. And then at that point, you might have one of the three nurses who maybe can grow into the supervisor role or move into the maternal child health nurse role.
So we're needing a motion to approve this with the modifier of including for adding the public health nurse supervisor. Approving the proposal that we had from May of this year. Is that correct?
Yes, but you.
And the order of hiring.
You've approved adding, creating those positions, adding those positions to the budget, so,
You're saying that we need a motion to propose that we hire the health services director first?
I think for the hiring sequence, for the plan. Or who are we hiring first? I mean, is it?
Do we have-
Here again, I don't feel like I can hire a clinical assistant. We did have nurses, right? So it would have made sense when we got approval for that. But we don't have an RN for the clinical assistant to report to. We don't have someone in that supervisor or director role. So who's gonna train that person? If we have a medical assistant, there's, without again, that director, who is the clinical assistant?
Who's doing these duties now?
No one.
No,
No
it's-
one.
We're not providing those services.
I mean, they're.
We weren't providing them, but now we're just gonna slip shot.
Where was Christina on this?
She was the public health nurse, communicable disease.
Okay.
So Kathy Hewitt is covering some of those duties. Linnea's covering some of the duties. Mike is covering some of the duties. Our maternal child health coordinator, Aubrey, is doing the non-clinical, non-nursing duties. Me, the administrative assistant, the director of vital records are trying to keep up with the temperature logs and the inventory for the vaccines. But this is also a problem. We need a VFC vaccine coordinator and a backup coordinator for those programs.
So if we hired an RN, you're saying even if we hired an RN, that person couldn't start without this health services director? Is that what you're saying? You don't want them?
I think based on our past experiences, they don't have that system and structure and support person. In the hands-on training, who's gonna determine whether they have the skills to move forward with providing services?
All right, I'm gonna attempt to make a motion. I motion that, with the current approved positions that we have, that we post and hire the positions in the order of health services director first. With, after that person is hired and trained, we then post and hire the 3 clinical nurses and the clinical assistant position as a second tier.
So just as a discussion, so what happens if we do that and then it takes a year? So can the health services director be giving vaccines and answering the phone until we get where we need to be?
To some certain extent, but I think that's where the staffing agency comes in because they have the people, they know, for example, they have people who they can bring on. And is that potentially gonna lead to more, oh, I don't like this, I'm gonna leave? It might, but unless we start paying a lot of money for posting these jobs, we're not getting applicants.
Do we need to have the discussion about the agency before we vote on the motion?
But we do need to do public comment.
We have, so
And the other question, what public comment do we have to do?
Yeah.
let's take, I think we can do them separately, so. Linnea, do you need Michael to say the motion again?
No, we got it.
Okay. So so is everyone comfortable or someone comfortable to do a second of the motion?
I second the motion.
All in favor?
Hold on, we have to do public comment.
Oh, yes, I'm so sorry. Yes, I'm sorry. We have to have public comment before we vote. Yes.
Yeah.
Is
Yeah,
there
yeah.
anyone with their hand up who wants to make public comment online? Linnea? Okay, seeing none. We shall take a vote. Do.
All those in favor?
All those in favor?
Aye.
Aye.
Aye. Okay, motion passes. Okay, so the next item to discuss is the emeritus healthcare staffing update. So. We had, can I, I'll just speak. So we had a contract. Lori was working with Dave on making some adjustments to the contract. There were a few items that needed changed. There, ongoing, she was working with Emeritus and had some potential people who we could maybe hire from that if we were able to get a contract, et cetera. And I believe at the commissioners meeting, they rescinded the Emeritus contract as was, correct, as it was correct at that time. So I think that Emeritus is I think it's a viable option to get us staff. And so what I would like to see is that we ask Dave to make the amendments that he thought were appropriate, get that contract to us. If he's able to do that before the next meeting, we maybe even have a special session to talk about the contract and vote on it so that we can move forward. So that's my assessment. Lori, do you have other additions?
Not a whole lot. I mean, I think that legal wants some changes made that I was unaware of specific changes. And so we just need to have those changes made so it can go to the board for approval and then the commissioners.
Why was it rescinded?
It is. So
Why?
I said, why?
Because because the board did not specifically approve this contract. But it's not essentially this contract either, if changes are being proposed and try to be worked out. Absolutely, I think that's something I missed. It's been a long time and just trying to actively work and get positions filled. And I sent the contract to legal in June. We had a phone conversation. He said, I got the contract, looks pretty straightforward. I did not realize that there were changes that the county wanted to have made, and I just kept trying to chug along in a panic, and so we're just gonna now have the changes made.
Does Emeritus operate as an agent to help us hire people? Or do they operate as like a staff solutions, a local staff solutions where they actually employ the people?
Yes, so when they're under the contract, unless it's a direct placement, so if it's a direct placement, then you can pay the fee and someone would come on as a county employee. Attempt to hire, so the person who is interested in the director position, it could be attempt to hire, so they're working for Emeritus, we're just paying, but then they would come on as a health department employee.
So every month that they work for us into perpetuity, we're giving them Emeritus some money for that person. being employed with us.
Absolutely, yes, you're paying that rate, which it is more, but we're not paying for the benefits of a county employee, which our benefits are really high.
Okay.
So marriages provides benefits for them.
Mhm.
We had some proposals, I think, in the last meeting or the one before that, where we discussed certain positions, creating positions and, or having, changing the salaries. And I
Mhm.
think those included benefits, so I'm having a hard time understanding how that fits in with this.
So I think it might be that, um, approval to move the health services director to that special occupations at the rate of $36 per hour. Okay, so council, did approve that. It's posted, it's $36 an hour. We haven't had anyone who's been interested in moving further in the recruitment process, kind of after those initial stages.
We had also had discussions regarding the budget. And I think that might be what you're remembering, because we're trying to figure out how much
Yeah.
these positions for cost.
Yeah.
But from a budget perspective, the not having to pay benefits and then paying the fee, is that a wash or?
It's close.
Okay.
I mean, it is still more
That's the weird
expensive,
question.
but-
Yeah, right, yeah.
Okay, so we don't really need a motion. Well, do we need a motion actually to ask Dave to work on updates to the contracts that we can then present at the next board meeting?
I'm not necessarily sure. I called over to the legal department today and asked them if they could get those updates to us. I was hoping to not.
So let's just put the motion.
Yeah, let's just do it.
Yeah.
I motion that we send this contract back to legal to have the amendments made that were necessary from legal. And then bring it back to the board for an official approval.
Okay, do I have a second, and then we'll ask for
I'll second,
public
yeah.
discussion? Okay. And then any public comment? Seeing none? No. Vote? All those in favor?
Aye.
Motion passes.
May I ask a question before we move on?
Yes,
Do we need to were you asking for us to vote tonight on these positions? Because what we did before, or to motion or anything, what I motioned before was for the ones that were already approved, did not include those newer ones that you were proposing. Do we need to do anything with that tonight?
I think it would be beneficial so we don't delay. The council has said that they don't want to hear requests for new positions until we're all in aligned with the direction we're going forward.
So you need a motion from us to say you may move forward to council regarding both of these positions or just the public health nurse supervisor?
I would say both of them, they're both current proposed in the budget for 2027.
Public health nurse supervisor and public health, maternal child health. Is that a supervisor at the end of that or just public health, maternal child health? Coordinator?
I think it would be one of the supervisor positions.
Okay.
And titles are, we can figure out titles.
well, we have to define it so that
Mhm.
it's clear to the council what we're essentially asking for.
And that's
So what positions would you like us to?
supervisor positions, public health nurse supervisor for the 3 public health nurses and a maternal child health public health nurse supervisor. That would,
So moved.
A second. Will that work?
Yeah. Okay, and do we have public comment? Okay, seeing none, we have a second and, all in favor?
Aye.
Aye.
Sorry to move backwards. I just realized that we needed
Thank
to-
you. Yes, thank you. Motion passes. Okay, so we are going to go through the next few new business items, all of which will require votes. So the first item is 2027 HealthNet HIP contract approval. That's the Homeless Initiative Program. You have this contract in your packet. I reviewed this, just had a question about item 5. which is the insurance, requirement. We needed a confirmation from our current contract for, so the Monroe County Health Department actually has a malpractice, contract. And so we were trying to get our hands on that. Oh, you have it.
No.
Oh, I'm sorry. What did I do?
Oh, that training and supervision of clinical.
Oh, I'm so sorry.
It probably,
I'm backing up.
it's
I-
probably, not relevant if the sequence hiring plan occurs because the clinical assistant would be supervised by the director.
You have a motion to do that.
Oh, okay.
Well, so we don't, do we need to table it? Or do we just need to say we'll have,
Yeah, it must be resolved in some way.
okay, so Lori, we're going back, I'm sorry, to old continuing business, discussion of nurse supervisor and MCH nurse positions. And unless I'm mistaken, I think we covered that in our discussion or not.
Yeah,
No,
with the
no,
training and
those are the-
supervision of clinicians.
Number 3, training and supervision of clinical assistant.
Okay, I'm sorry. Training and supervision of clinical assistant, Lori.
So the purpose of having this item for discussion was to discuss if we don't bring on a health services director first and start move towards this plan, and we have nurses 1, 2, or 3, and then if we're gonna hire a clinical assistant, who are they going to be overseen by? Who's gonna train them and supervise them? However, I feel as though if we are going to move forward with the plan to bring on the health services director and then the 3 nurses and the clinical assistant, that issue will be resolved by that plan.
I motion that we table number 3, training and supervision of clinical assistant until after a time in which the health services director is employed.
I second.
Is there public comment? Seeing none, all in favor?
Aye.
Motion, aye. Motion passes. Okay. So moving to new business, discussing the homeless initiative program with Health Net for 2027, the contract. This is an item for approval of the contract. However, what I don't know from item 5 is if we have enough coverage from our current contract for medical malpractice.
I do not have the answer to that question yet. We've reached out to USI, who has the policy, to try to get a copy of the policy. No one has been able to confirm that we currently have this coverage or that we need to add it.
Okay, so if someone could make a motion to add this item until we can have more information until our next meeting.
I'd like to make a short statement, then I'll make a motion.
Oh, yes.
My statement is that it seems to me that if you go to an insurer and say, hey, do I have enough coverage? They're gonna automatically tell you no. That being said, I do make a motion that we table this discussion until we have the information needed to make a reasonable.
And how much is this? How
decision.
much are we?
It's $1 million for,
Which
No,
is
no.
standard.
No, I mean, how much? It's 135,000.
oh, I'm sorry, the
Oh,
contract
yes,
is for 135,000.
135,000.
And that's the same funding as we gave them last year, right?
The same amount, yes.
Yeah.
Mhm.
They were asking for additional money,
150
which we didn't approve.
Mhm. That was 155. They wanted that 20,000 to use. We have been helping to purchase some supplies that we've been able to help support with the glucometers and different supplies that.
I second the motion.
Okay, any public comment? Sarah? Yes.
I'm just, I'm crazy about this program. I think it's great.
Mhm. I do too.
I love the data that we got about the drop off
Mhm.
in patients seen in the ER during those hours. What I really would be curious to know is, and I'm sure it's going to be really hard for us to obtain, but it'd be very interesting to know how much IU has saved because of this program. And I don't know if our ER director could help us even begin to understand what the financial benefit has been from this drop off of the homeless population being seen during those hours.
So it is in the reporting and metrics section of E. It says, of those seen by Hip Street Medicine, compare with visits to IU Health Emergency Department. So if you are wanting to make, I'm asking in general that we know what the numbers looked like, because we saw that report and that was fabulous. We had a graph, we had all sorts of information. But I'm wondering what the financial benefit to IU Health is from this action on our part and that of HealthNet. Because I think it should be substantial, and that patients who have been, I think it's also a clear benefit to the community who wants to be served in the emergency room. And that they can be seen much more rapidly. And that's why I'm saying I don't know how one would even begin to wrap their head around it, but I suspect that there is a way of beginning to understand the financial benefit.
So as of July the 1st, I'm no longer the medical director of the emergency department. I've given those duties off to Dr. Matthews. I did have a discussion with Mr. Ross, and he doesn't know the answer, and I don't think anyone knows the answer. I don't think that there's been you can say you've decreased this number, or there's been a decrease in the number of people who visit the emergency department, but it's hard to say that it was related solely to these changes. And then the amount of money that's saved, I don't know if they've made that determination, but I didn't get that number from Mr. Ross when I had the discussion with him when I was still medical director.
Mhm.
So I am in favor of having a discussion with IU Health regarding this, but I don't know how to get those numbers.
Yeah, I don't know how to quantify it, and I'm sure there must be some method. Maybe somebody who's really smart about this stuff would be able to. But I think, I know that when I talked to the health administrator for the state, she was very excited when I told her what we saw in terms of numbers and the impact that these Health First Indiana funds had had, not only for the homeless population themselves, but in terms of real use of these funds to deal with people and benefit the whole community, again, because there is more availability for emergency services than for the rest of us. So
I think one of the problems that you run into is how to quantify it in the face of IU Health having its own initiatives outside of the community health or the street nurse doing the thing that they do. There's other initiatives that of which I'm aware that were ongoing and ramped up over the past couple of years as well, that were also designed to keep people out of the emergency department. And I think that's where you run into problems with saying, well, here's the financial benefit. So because we benefited you, why don't you help us? I think it's very difficult to quantify it. Not impossible. I don't know. But I think when you approach IU Health, or when we approach IU Health, we have to keep that in mind, that that's going to be a likely response, is what I would imagine. And I think that's reasonable to say that, because I know there are other efforts to decrease these visits that may not be necessary. So.
Thank you. That was really helpful.
So still seeing no raised hands for public comment. We shall vote on Dr. Teague's motion. All in favor?
Aye.
Motion passes. Okay, and now we're going to talk about the full blood pressure screenings by the maternal child health coordinator.
So the question is, so originally this gold program was built into our public health nurse school liaison position. When that position became vacant, we had already previously been in an agreement with Indiana University, and we were working towards providing this program. So I spoke with our maternal child health coordinator to see, do you have the capacity, the interest in taking this on? And when would this maybe best work with your schedule? So through further discussion with that, she identified that working with Indiana University fall would work. So as part of that process, we were really hoping to be able to collect biometric data that we could help to track program evaluation and outcomes. Since our maternal child health coordinator is not a nurse, the question is, do we feel that it would be appropriate and okay for her to be trained under our standing orders to be able to do the blood pressure screenings for those 13 and older as part of the program, so that we can still collect that data?
Is it purely to collect data as a population data, or is it to collect data and then act upon it in individuals' cases? For example, if someone you go into a school, you take a 50-year-old's blood pressure, it's 200 over 130. Is there an action that's to be taken? And if it's not, if it's elevated but not an emergent where they need to go to the emergency department, is there some action to be taken by them, or is it simply to collect data on a population basis?
So the standing order does outline the criteria and then what action should be taken. So if that was identified, you should seek help immediately. You should follow up with a doctor in a certain period of time. So those would be the recommendations and the guidance, to my knowledge.
Is it possible for us to review those? Because I gotta tell you, we get people from offices all the time that are sent for emergent, you know what I'm talking about?
So dumb.
Emergent blood pressure readings that are not emergent blood pressures. Because, like 180 over 100, oh my God, you gotta go to the ER right away. And there's nothing to do for that patient if they're not having symptoms.
You're not dying. Go back to your primary care.
Is there some way that we can just, I'm adding on to our work, but can we review those guidelines and maybe look at them and see if they're appropriate?
Sure, we have all that information.
What kind of blood pressure cuff is this person using? Is it electronic or is it?
Yes, it's electronic.
So do we want more information on the standing orders, or can we amend those at some later time and approve that the maternal child health coordinator with appropriate training can assess blood pressures for those over 13?
I would like to see those and review them, and also review the type of training and review the training that they're going to receive to make sure that it's, reasonable for the situation. You get into a whole forest of weeds, sometimes these electronic blood pressure monitors.
Okay, so can I have a motion to table this until we gather more data and address it at the next meeting?
So moved.
Okay. And do I have a second?
Second.
And do we have anyone wanting to make public comment? And seeing none, we'll take a vote. All in favor?
Aye.
Motion passes. Oh, sorry, excuse me. Aye. Motion passes. Someone else can have this one. Okay,
Put you down as an abstention or,
no. Okay, so our next item is to discuss the part-time public health nurse request. Lori?
Yes. So again, and just trying to think and consider different options for our nursing services. Actually had, some candidates who are not interested in part-time, but they would be interested, or not interested in full-time, but they would be interested in a part-time, opportunities, even if it were just short-term, or if it were long-term, kind of here and there. Additionally, just considering the large picture of, you could abruptly lose a nurse and then have a vacancy. It would be really nice and easy to be able to have a, I'll say pool, even though it's not necessarily a pool, but maybe one or two part-time nurses that you could call upon and see if they have any availability to help cover specific services, that need to be performed for the health department. This essentially, it's not about adding overall capacity. It's about being able to have options so that we have a flexible staffing model. So this, in my mind, this is similar to PRNs at hospitals. They'd only be scheduled when organizational needs occur. They'd only be used within the existing funding available, and would have the ability to maintain our clinical services. Now this, it's hard to say. I think the council number one wants a defined job description. So what are these part-time nurses going to do? Has the board approved that you can move forward with part-time nurse positions? And how do we know what we're going to pay them if we don't have a defined part-time position for the nurses? I think that you have to kind of include that a lot of those different duties and activities, because you might not know, you might just be wanting to call your part-time nurse and see if they can participate in a vaccine event for the community. You might have coverage that's needed for one of the nurses because they have to be off for 2 or 3 or 4 weeks, and to be able to provide some stability for those services. So I think it can make it challenging to pin down just very limited duties and responsibilities. But overall, I think that being able to have the option to have part-time nurses to fill gaps would be really important, again, just for the long-term stability.
Are we looking to say, yes, let's go evaluate this, let's try to come up with the job descriptions, or are we looking for something else from the board tonight?
I think the first move would be that you would approve going to council to request that we can develop part-time nurse positions.
What do you define as part-time in hours?
Well, it would be under the benefit, and I don't know what that is at the county, but I don't know if that's 24 or 28. They wouldn't be able to exceed that certain amount of hours that could over time for the year that would make them eligible for benefits.
I think that it's a difficult, I think long-term, in an ideal world, it would be great. I think it's gonna be hard, very difficult to go to council, especially with all the current changes we're trying to make. That is just my assessment, but.
Can you tell us, Lori, what is council's position on part-time employees? My understanding is that they are, not only is there this hiring freeze, but they do not want any part-time employees. Is that correct or not?
I am not aware that they don't want any part-time employees, period. But yes, there is the hiring freeze.
And my understanding from council administrator is they are not going to approve part-time employees. That's my understanding. I may be incorrect, but that's what I have heard. And so I'm wondering whether this is, I think, again, okay, that it, and Lisa, that this, under the best of circumstances, if this were, you know, if we were independent of the limitations that are imposed on us by council and commissioners, that it would make perfect sense. We know that on Miller Drive, we had part-time positions. We had 2 part-timers. And so maybe more, 3?
I think it was more than that. They had a couple that were.
Yeah.
Mhm.
Yeah, so I mean, it was great. They liked it. But this council, we're never going to get that proposal through. And that even asking the board to approve something that is not gonna happen when you take it to council. Ultimately, I'm afraid it looks like we're just getting beaten down again. And so I would just suggest that, you know, wait until things get a little looser and work with council, help them begin to, maybe with new liaisons, we don't know. But, you know, as we know, things financially across the county and the state are going to become much worse. Much, much worse for all government. And so to try to get through to them what and why this is, I think is a losing proposition. And I earnestly don't believe we can take any more losses at council's door, personally. You know, yes, it looks like we're fighting the good fight, but I don't know that it behooves the board to ask for things that are not gonna happen.
I was not aware that if council has said they don't want part-time positions, period. So if that's the case, that's not something I was aware of. You know, when we have people reaching out to say, hey, I know about this change that happened with IU Health. I can't come on full time, but I'm really passionate about the health department. I'm more than happy to come on in a part-time capacity. And we see the work that needs to be done, and we're in this critical situation. I think that it means a lot to me, and it's really important that I explore every single avenue that can be explored to try to get the services into the community. And that's simply what I'm trying to do.
I get it. You
I-
know,
I will say that respectfully, I'm gonna take a different position than Dr. Rutterman.
please,
I believe if I look at the world, if I look at the state of our government, federal and statewide, and if I said 10 years ago, this is where we're gonna be, I would have said, you're out of your mind, that's not gonna happen. And I think that because you never know which way the wind is gonna blow, and pendulums being as they are, I would say if we have a vision and we have a reasonable vision that can help improve the health outcomes of the people in our community, then I think we should propose it to the council. Because I do believe fortune favors the bold.
And I agree too. My opinion is, we are, from my perspective, we serve the community. And if ultimately we think that, hey, you know what, we're not getting any bites on these positions. We've got the services we need to provide. We have people calling and saying, I can give you 4 hours here, 4 hours there. If council wants to shoot it down, council,
They can do
right,
that.
council can shoot it down publicly in the
Publicly,
light
yeah,
of the
yeah.
community and see
Yeah.
that we, as the Board of Health, are saying, here's what we
We
need.
care, yeah.
We
this is
care.
what we need.
And council has said no. So, we're trying to do our job.
Getting it on record,
Right, that's right.
on the record, yeah.
And that's how people vote, and so having people put stuff on records is important.
It doesn't really make sense that they don't really want part-time people because you have to work a certain number of hours to be eligible for benefits. I mean, I think it was 21, I think in private, my practice, you had to work 21 hours a week in order to be eligible for benefits. Even though I will go on record as saying I always provided
Let's be clear.
Yeah.
Like a record show.
Yeah. But I don't think that, but legally, you're not obligated to do it for any more than 21 hours, or at least that's what it was. And so I'm all in favor of requesting part-time positions, making our position known. And let's see what happens. Yeah, I agree. Make them shoot it down in public.
It
Was
sounds as if if that's gonna happen, then it really needs to be made clear how many of the positions at IU, of our IU nurses on Number 5 were part-time. I think that understanding that this is operated very efficiently and effectively with part-time people may help that. I want you to be aware that it may be a real losing game.
And you know what? I think that all I can do is try.
Yeah.
That's right.
I'm the one in the chair every day,
Yeah.
trying to get people in here to do the services.
Yep.
Okay, so what what motion would be most helpful at this juncture? So it gives you time to do what you need to do to get everything ready for.
I think the first step is it has to go to council for approval to move forward to develop a part-time position during the hiring freeze.
So you need a motion to,
Well, we're
oh,
actually,
sorry.
yes.
No, go ahead.
So how many, so in an ideal world, how many part-time positions would you like? 2?
I think 2 would be okay, and I think that it's important to clarify that when I'm thinking about this, I'm thinking more of that PRN
Right.
capacity.
Right,
Yeah.
as
Okay.
needed, not doing the.
Yeah, it's
not
we're gonna call
all
every
the time.
week and we're gonna say, we need some help, not you're scheduled for 20 hours a week,
Right.
period.
Correct,
Okay.
because over the past few weeks, if we would have had that person, for example, that reached out, it would have been really nice to say, absolutely, let's get you in here tomorrow. And we'd be providing some services right now.
Mhm.
And so I don't
Cool.
think that it's a lot.
Could we, instead of calling them part-time nurses, could we call them PRN? Is that something we can do? Like, if we just name it?
I think you can title
PRN?
it whatever you want.
Okay.
I think PRN makes it more clear and it sounds better. I think that's a little easier pill to swallow.
Does that work in the county structure, though? I do not know the answer to that. Do they have as needed positions?
I guess, yeah, because that's an interesting, like, if we get a part-time position and then we give them 0 hours, like, is that a problem?
I don't think so, because my understanding, I don't know what's changed from when I've been here and what's current now, but it's my understanding that you would be scheduling them at the capacity that you need up to 20 hours. And some of them are temporary, just seasonal. So again,
Oh, that's true.
it would,
Okay.
Okay,
yeah,
so is the part-time language okay? Or should we do as needed?
I don't know what's the
Well,
title.
it sounds like that,
Oh, yeah, that's an excellent.
That's a good idea.
Supplemental.
yeah, I think that sounds better because I think if you say part-time, they're gonna be thinking about how many full-time equivalents are you creating?
Mhm.
And that, supplemental or PRN, they may not even understand PRN because they're not in the business.
Supplemental.
Yeah, supplemental.
I like supplemental, 'cause that's something they would understand.
Yeah, okay, so can I have a motion?
So the motion to go to the council to ask to develop the supplemental positions
As needed.
as supplemental positions as needed for, what is it?
Public health nurse
Public health nurse.
and 2 positions.
Yeah, that's to include in that, because we envision this as 2, because you don't leave that
maximum.
open-ended, you end up, yeah.
Is that adequate for you, Renee? Okay, and can I have a second?
A second.
And do we have any public comment? Seeing none. Can I have a vote? All in favor?
Aye.
Aye. Motion passes unanimously. Okay, so now we have approval of septic replacement modem, or sorry, yeah, memorandum
Understand.
of understanding. So this is the contract that is amending the language that shows that the funds. Excuse me, we will reduce the interagency agreement by $252,712.91 for the septic program. Because those funds are being moved to other programs because we couldn't get those funds used for the septic program because of the federal guidelines and meeting all the criteria, et cetera.
Weather.
Yeah, and the weather. So we have to vote on the changes for the contract. So I need a motion.
I'll make a motion to approve the amendment or the change to the, it's the date, right? And the funds, the changes, I'll just make a motion to approve the changes in the contract.
A second.
Okay, and we have public comment? Seeing none, all in favor?
Aye.
Motion passes unanimously. The next item is approval of the Red Cross agreement. I do need help with it, 'cause I'm not sure.
I do too. That's why we have Linda in.
Okay.
So, items 5 and 6, sort of go together, as far as the Red Cross agreement goes. Public health preparedness, so our division, has been looking at how can we expand some of our training in the community. And Linnea has looked into some different options. She's received training, and if you're comfortable talking about it, I think you're the most qualified person to do so.
Sure. So I've received the certification training to be a Red Cross authorized adult and pediatric CPR first aid AED trainer, as well as basic life support, the babysitter course, the associated coursework there. And what we would like to do is to add to our preparedness education the opportunities to take the CPR training, certification, either adult or pediatric, and then to offer the babysitter training. Well.
Good idea.
I think it's awesome. The agreement, did everyone receive the agreement before the meeting today?
It was too large to take the place to keep it.
Okay,
Okay.
Now this,
can we,
paper copies?
Yeah. distribute paper copies, and then does that mean we need to vote on it at a later time?
I would say. It's up to you.
Can you summarize it?
Yeah.
Someone.
I don't really need a paper copy.
We've actually, I think it's been a long time we've been discussing this, and there's actually been a lot of back and forth. I've actually been like, I don't think we can do this. This is gonna be a lot. And then circling back around because of counting processes, right? Okay, what other ways can we actually maybe do this? So we've worked out the program. So we've developed a form that individuals would complete a Microsoft form to sign up for the classes.
Okay,
And then you all register.
So we would register them, and then either they could pay through the Vital Records office, or in the phone, when we call to confirm they would indicate on their form how they would like to do that. And then as long as that's taken care of before they show up for the class, then we can.
So this is the general public would go on the website, find this form, fill it out, and then you're providing the training.
Correct.
And
Okay,
they're either bringing in the payment or they're calling Vital Records to make the payment over the phone or collecting those fees. And then the Red Cross is going to invoice us because of our payment structure. That's really the process that we need to be able to use. So we collect the fees and then we receive the invoice through the Red Cross to pay that, and we're using their materials. So
Fantastic.
it's
Yeah,
all Red
that's-
Cross materials, and
They update their materials every few years, and in order to stay current as an instructor, you have to redo training to make sure that you've seen and done the most recent materials, so you have access to it. And
grant funding will be used to purchase the supplies to start the program. And that's been cleared and taken care of through with legal. If we need ongoing, we could also use Health First Indiana, so both Bryce and Linnea's positions will be Health First Indiana funded next year. So they'll be obtaining, verifying residency anyway, so we'll need to supplement with other funds in the future.
Yeah, the rate of survival of out-of-hospital cardiac arrest, if bystander CPR started, is 5 times greater than if it isn't. It's ridiculous. They go to King County, Seattle, your chance of surviving out of hospital cardiac arrest is so much higher than anywhere else. It's just, this is a great program, yeah. And then the thing is, the beauty of it doesn't even matter, you know, count this number, it's just get it started, just start pumping on their chest. It's a world of difference.
so our motion, I think, is to approve the agreement with the Red Cross. Would that be correct? Okay, so can I have a motion?
Sure,
Steve?
I move to, that we approve the Red Cross agreement, I guess.
Okay, can I have a second? Okay, and do we have any public comment? Seeing none, all in favor?
Aye.
Motion passes unanimously. Okay, fee code change proposal. Now, I noticed there are two.
Yes, so as part of developing this program for implementation in the health department, we would need to actually add into our fee code what the fees are that we're gonna be charging the public for these services. So there are two different proposals based on two different fee collections and what is actually being covered. Let's see. So one is covering the cost of providing the service, so our supplies, our personnel. Typically, that's what we would do. What are you charging to just cover your expenses? So not making any profit. One is if we want to intentionally subsidize fee costs, which is legal, we could do to provide a discount and essentially not collect fees that would be covering the full amount of us providing the services. Again, talked with Linnea about this and you can speak to it, and I felt it was appropriate and fine to have both options, and then the board can discuss what structure they think is best for the department and the community.
Could we get some idea of how much the fees would be?
Yeah, on page
yeah,
5.
it's in here. So yeah, on page 5, the red
Yeah, it's
section is right, different copies of the same document. One has a higher amount, the other has a lower amount quoted for those fees. There's those calculated.
Okay. What's in the red there?
Operational cost is
Yep.
to provide the training.
A second one.
So proposal one is the baseline.
So, yeah, proposal takes out the cost of labor that's actually offering the training. So it sort of, it doesn't take all of it out. But it basically assumes that all of the expenses incurred in providing the program would break even if we had a class. So there's like no additional revenue.
Here it is.
Yeah, there
Right.
it is. That's right.
Cover the actual expense of the materials, and it covers much of the instruction cost as well. The higher amount, covers all of our expenditures assuming that we have the minimum enrollment for the class. So this would be the model that you'd use for like a revenue generating class. So it would mean that the expenses associated with the labor in teaching the course, as well as all of the equipment and supplies utilized, and the certification fee, which is what we then would owe to your Red Cross, would be fully covered with a minimum of 3 students enrolling in that class.
Okay, so,
Some of them generates revenue,
yes,
all enough.
Maybe.
Does not.
unless,
Well, maybe.
unless we only get 3, right? Then it
Correct.
covers the minimum,
That's correct.
right? So what? If I heard correctly, the initial upfront costs of this are being paid out by grants that we've already gotten we're using.
Correct.
Okay, so when we host a class, what is the cost we incur?
The cost per class is the sort of fixed labor cost, which is however many hours it takes to teach the course. And then the certification fee, which is what we are invoiced by the Red Cross for. And those are all listed in the.
Those are in
agreement.
Oh. okay.
So the 65 versus the 105 for the first line.
Right,
The CPR.
that's,
For example, the certification fee for that $65 one, for example, is I think $55. So $55 of that goes directly to the Red Cross to pay for the certificate. And the remainder is paying for just the supplies that are distributed, like the little first aid kit that they get, things like that.
all right. So and what's the maximum size of a class? So you said 3 is the minimum.
3 is the max, 10 is the maximum budget, based on the budget that we created for the like management systems.
It doesn't sit right with me to make money off the endeavor. I think these are pretty steep fees, honestly. People, given what people make and to live in this town, or what people are making in this town, these are pretty steep fees, in my opinion.
I agree. And is IU Health Community Group doing any of these classes?
Well, their trauma and injury prevention team,
Yeah,
provides them in the community.
yeah.
What was one of them? American Heart Association.
Amy's group I'm talking about.
Yeah, Amy's group they do these things.
I
So,
thought they still did the babysitting and those kinds of things, but
Lisa, Lisa School of Health, I know at least was doing the babysitting, I think some of the schools.
and I have a comment. My meter's gonna run out in about 5 minutes.
Oh.
Longer than I expected.
I'm in on right at this second.
So do we have any, do we have a motion? For which proposal you would like to?
how many of these classes I'm trying to, we've been talking about finance, we've been talking about all of those stuff, like, are we offering these classes once a month? Are we offering them every 2 months? Or are we offering weekly, like?
Our proposed schedule with our preparedness education would be to offer it 1 to 2 times per month, depending on what the initial response is. And then to offer the babysitting course 3 times per year.
It's like that matters in regards to, if we go, I agree, we should go with the lower fees. But if you're gonna take a hit of $500 every time you do this, that's gonna probably matter to someone.
In building a capacity for your workload, how that might fluctuate.
My understanding of it, so maybe I don't understand it. My understanding is proposal 1 is a break even charge. Proposal 2 is a make money
No.
charge. Is that not true?
Proposal 2 is a break even at 3 participant charge.
Okay,
And proposal 1 is a break even at 10 participant charge.
I see. Okay. Then that's
And that's why I've been asking the questions, right? Like,
yeah, that's what they're gonna, yeah.
I would say that barring grant funding, additionally coming out of somewhere, the absolute lowest that we could ever charge would be the amount that we have to pay to the Red Cross, right, certification. which like for that, I think it's 65, this is the first one, would be 55. So, the floor is kind of different.
So can we do something like?
Actually, one thing,
Sure, go ahead.
3 seems small to me,
Yeah,
and 10 seems big. Can we amend it to make it somewhere in the middle, like 5?
I
And
think it's set by, is it set by the Red Cross or?
The maximum is set by the Red Cross. Technically, the minimum could be whatever we see fit for like a skills assessment. They recommend at least 2. My preference is to have them in pairs, so either having 4, 6, 8, or 10 participants.
sure,
But
I would hate to take the hit on, as he was pointing out, take a $5 hit twice a month on all of these things. But, you know, if it's a $200 hit, that might be different.
Mhm.
Can we set it at like 6? And vote for a proposal that says we break even at 6?
And that's, I was going to ask, like, could we motion to do proposal 1, but have a minimum number of participants of 6?
Yeah.
Or we cancel the class.
Yeah,
I will say,
Can we do
Well,
that?
that will probably end up in the class being canceled a lot, don't you
Okay,
think?
well, or whatever the number is. right?
yeah. I mean, like, if we go by our preparedness university courses, which are free of charge, they kind of come in waves. So we'll have some classes where we'll have, 10 to 15 participants, and then other classes where only 3 of the registered actually show up.
What if you moved it to like quarterly or a couple of times to try to get people, or maybe monthly, maybe
Yeah,
more
yeah,
people would
yeah.
get stacked up.
yeah.
Yeah, we can do that. We can definitely.
And then set at the minimum, they have a minimum of 6 people. We probably,
Yeah.
from what you're saying, it sounds like that might be a sweet spot.
Can we do a minimum of 4?
So is that like the same math from proposal number 1? And just amending the minimum to be like the functional, the number of students to be.
I just hesitate to, I understand the thinking, but I don't wanna add more parameters to Renee's day-to-day. I don't know, maybe, I'm not a big fan.
Which things?
Just to give, not set parameters, so that she can just manage the classes without having to cancel the classes and then meet criteria, and it's just gonna be
So-
a bigger hassle.
So just set it, we're gonna have it
I
every
think we
other
should
month.
just
every other
set-
month.
Yeah.
And we have a minimum of 4, or just set every other month and that's it. And we charge.
We
one-
say every
we
other
charge
month, and then we're
fee.
gonna reevaluate
Charge
how
fee
these classes are, right? And if they're massively full, we can add more.
Perfect.
And then
So how often?
So we
Every
need
other
a
month.
motion.
set by monthly, every other month.
I think I said that. and
You
that's
owe
totally
money.
wrong.
You owe money, yeah,
You owe money.
every other month. And then are we saying fee schedule number 1 or fee schedule number 1? Okay.
We can have a motion.
I motion that we adopt fee schedule proposal number 1 with a frequency of the public health preparedness education at every other month. Frequency.
Perfect. Do I have
I
a
second.
Okay,
Second.
and do we have any public comment? No. Seeing none. All in favor?
Aye.
Motion passes unanimously. Okay, so would any board members or the health officer like to make any additional comments before we adjourn?
I have one comment, and I know it keeps people from the callers, but what do we know about the Vax Care? Because we said we wanted to.
So, I connected, with IU Health and for more information, what specifically what they were looking for. And, I knew that Dr. Robinson was out of town. I suggested that you and I could meet with them to better understand, and the feedback I received was disregard the request from VaxCare. They were trying to look at a way to, avoid having to re-enter in all of the information, but, just disregard and but kind of moving forward.
Thank you.
Yeah.
Thank you for doing
Yeah,
that.
yeah. That was a fun discussion.
Yeah. Gosh.
Is there, oh, but yes.
Motion to adjourn.
Has there been and Sarah, do we have a motion to adjourn? He motions to adjourn.
Second.
All in favor? Time is 6:40 PM.
Yes.
Thank